Good evening, everybody, and welcome to our webinar this evening, Radiotherapy After Laryngectomy, Understanding Skin Changes, Implications and Management Strategies. Okay, so we'll try and just move things on. It's been a day of technical glitches, so I'm going to put that out there before we even start. And as you can see, we're on a bit of a new platform, so we are still familiarizing ourselves with it. Okay, so before we get started, I am just going to kick off with a few formalities, beginning with our disclaimer. Atos Medical provides a forum to facilitate discussions and questions. Nothing in this session provides any diagnosis, clinical advice, indication, guide, warranty, or guarantee. The discussion and answers provided are not specific guidelines or endorsements. Nothing in this webinar can substitute individual advice or guidance from a qualified healthcare professional. By enabling a virtual forum for this session, Atos Medical is not providing medical advice, nor does it specifically endorse any of the medical opinions of any panel members. Testimonials relate to how one individual has experienced the use of a product, and not every person will get the same results. Atos Medical does not suggest, imply, or make any claims other than those detailed in the product manual. So as you can see, we are currently using this new platform for our webinars. So again, should you wish to ask any questions to our expert speakers at the end, please use the Q&A box in the top left-hand side of your screen. And we will attempt to move the slide on. Sorry, Mary, it looks like you're going to have to move the slide on for me.
Just bear with me, I'm trying as well.
Everybody's trying to move it on, and then all of a sudden it'll skip 6 slides. So bear with us.
Okay.
There we go. Fabulous, thank you. So let's introduce you to our expert panel this evening. So we have Monique Hines. Monique is a speech and language therapist with over 10 years experience, specialising exclusively in head and neck oncology since 2016. She's based at the Mount Vernon Cancer Centre in the UK and works with patients who've had surgery and patients undergoing various cancer treatments, including radiotherapy, chemotherapy, and immunotherapy. She's very passionate about helping people with communication and swallowing difficulties following head and neck cancer, and thereby enhancing their overall quality of life and overall well-being. She's committed to delivering high-quality, holistic, patient-centred care. Our next presenter is Susie. Susie is the lead nurse for the tissue viability at the Christie Hospital in Manchester. Susie has 22 years of wound care experience, both in the acute and community setting, and she cares for patients with acute and complex wounds. She has been working at the Christie for nearly 10 years. Working in oncology settings, she is faced with challenging oncological wounds every day. Dealing with malignant fungating wounds has prompted her to carry out more research in the management of malignant fungating wounds, and recently completed a pre-doctoral fellowship focusing on this topic. Susie has been presenting her work nationally and internationally, and has also introduced skin tone assessment into the daily skin assessment in the Christie, for which she is nominated for the Nursing Times Awards 2024. She's published several articles about this particular topic, skin tone assessment and pressure ulcer prevention, in various journals, including the European Oncology Nursing Journal, and she's also co-authored a chapter in the Non-Melanoma Skin Cancer book. She is a teaching faculty for the ESTRO, European Society for Radiotherapy and Oncology Society, currently part of the team developing the consensus document for the management of malignant fungating wounds. She frequently speaks at different events covering topics related to this, and management of radiotherapy, skin reactions, and skin tone assessment. We then have Lacey Peck. and Lacey is a head and neck specialist nurse here at Atos for Atos Care. And within 13 years of post-registration nursing experience, Lacey has worked across various specialities, including critical care, high dependency, oncology, surgery, ENT, and complex community care. But for the past 2 years, we've been privileged to have her here as a head and neck specialist nurse, and she has positively contributed to patients' journeys with altered airways. Lacey thrives on educating patients, their families, and professionals to dispel fears and ensure gold standard care. And I'm going to be the moderator for today. So my name is Faye. I'm one of the senior clinical educators and a speech and language therapist by background, and I'm going to be taking you through tonight's webinar. Next slide, please. Okay, so as we all know, there is varied practice up and down the UK when it comes to management of laryngectomy patients during radiotherapy, particularly in how we manage their pulmonary health via adhesives and HMEs. As there is no real consensus at present, we thought that we would hold this webinar to look at some of the current practice that we have around the country. We do have a packed agenda for you today, so we will cover the effects of radiotherapy for our laryngectomy populations. Then Susie will talk about the management of skin reactions based on the Christie Hospital protocol. Monique will then discuss the management of laryngectomy patients during radiotherapy from an SLT perspective. And then we have a pre-recorded video of Lacey and one of her patients discussing their own experience. There will be an opportunity for you to pose your questions to all of our presenters at the end of the webinar, so please do make the most of the Q&A. Next slide, please. Okay, so why radiotherapy? What do we know? So we know that small focal tumours in the larynx may be successfully treated with radiotherapy alone. We also know that larger, more extensive tumours might require surgery first, followed by radiotherapy. What we know is radiotherapy uses controlled doses of high energy radiation to destroy the cancerous cells. And in order to minimize the damage to the healthy cells, a mold of the face is taken so a mask can be made. And that mask is actually fitted to the bed during treatment to prevent unintentional movement. And obviously, as we know, radiotherapy can be used in conjunction with chemotherapy as well. Okay, next slide, please. So how does this impact on our patients and what do we tend to see? Tiredness is one of the biggest symptoms. Obviously, that worsens over time and it can persist for some weeks after the end of their treatment. One of the other side effects that we will see and will be discussed today is that reddening or darkening of the skin, and it can feel very sore and sometimes result in a breakdown of the skin. It usually can improve within 2 to 4 weeks of the end of treatment. But again, this can impact on how we manage patients' pulmonary health and the use of adhesives and HMEs during their treatment. Patients can develop sore throats or sore mouths, and it can be painful to eat and drink. That can reduce their oral intake. It can also mean that they have difficulty with oral care and hygiene, and that may also impact on their dentition. From a swallowing perspective, they may feel that there's something in the throat. They may require some enteral feeding, and it can usually be worse around 10 days to 2 weeks after the end of treatment. So again, even when treatment is finished, they can still persist with some difficulties. Again, depending on where that radiotherapy is delivered, they may develop a dry mouth, and that can result in food sticking in the mouth, and it can be quite uncomfortable or painful. And we expect that during their radiotherapy, patients will go on to develop some voice changes. They may become more and more hoarse as the treatment progresses, but hopefully this will return post-treatment, but they may still sound different. So that's just to give us a little overview of why we're here today. I'm now going to hand over to Susie to discuss how the Christie protocol helps in the management of the effects of radiotherapy. Next slide, please.
Thank you, Faye. As Faye has already introduced me, I am Susie Pramod from Christie Hospital in Manchester. I work as a lead tissue viability nurse in the trust. Next slide, please. The content I am planning to cover today is actually physiology of the radiation dermatitis and some of the risk factors associated with this. and signs and symptoms of radiation toxicities, and the skin care while patient undergoes radiotherapy, and also radiation toxicities grading scale, what type of grading we use at the Christie's, and some of the wound management plans for the side effects. Next slide, please, Mary. So just to give you a little bit of introduction, radiation dermatitis is one of the most common side effects of radiation, and it can range from mild erythema to moist desquamation, and very, very occasionally you see ulceration. In my work at the Christie's, I have never seen an ulceration in any of the patients. And all patients are at potential risk of developing a reaction within the treatment field, and approximately 85 to 87% of these patients experience a moderate to severe skin reaction, and in which 10 to 15% will progress to moist desquamation. All damage, any damage should be minimized using the intervention based on the best practice statement, which you should be using the evidence-based guidelines for that. And we also know that there is lack of randomized control trials to evaluate prophylactic skin care interventions. And it is very sad that most of our other treatments, we have got some prophylactic interventions, but here there are a couple of prophylactic interventions. However, we are actually not able to, we haven't got a randomized control trial to say this is going to work the best. And we also know that patients with the radiotherapy, when they develop the radiation dermatitis, it affects the quality of life, pain, and premature interruption of the radiotherapy, which is not actually going to be good for our patients. Today's session, though it is also going to be laryngectomy, this session is probably cover radiotherapy aspect in full. But we will will give you some of the information about the laryngectomy, which we will cover. Just to give you a physiology of radiation dermatitis, radiotherapy skin reaction, actually the cause itself is the absorption of the energy from the radiotherapy, which causes the process of which altered the process of regeneration. Whereas in the burn injury, the cause itself is a trauma or whatever cause of how it actually caused the burn. And we also see that in the radiation dermatitis, we see the delayed reaction, and straight away it doesn't cause any reaction. It might take a few days before we start seeing the reaction. And in the burns injury, you'll see immediate reaction. And also, epidermal layers are the most affected, and we see the sequence of damaged basal cell migrates upward to the surface of the skin, whereas in the burn injury, damage occurs downwards. Just to give you a little bit of outline about the skin damage. Next slide, please, Mary. Just say damage to the basal cell proliferating layer of the epidermis. So it's the top layer of the skin is actually mainly affected, and that is imbalanced between the production of the cells in this layer and destruction of the cells at the surface. Next slide, please. Just to give you a little bit of idea about radiation, how it develops the skin, how the skin reacts after they start the radiotherapy. Once it commences, activates the inflammatory response, and within 10 to 14 days of the first treatment, damaged basal cell migrate to the skin surface, and erythema starts. Then after that, dry desquamation is further skin damage occurs. New cells reproduce before the old cells dies. Then no new cells are replaced. Dead tissues, which causes the moist desquamation. And also treatment, when the treatment completes, as Faye was saying, 10 to 21 days of after the treatment, the basal cells still trying to recover within the 10 to 21 days, and the new skin start to grow. Next slide, please. There are this is also where some of the extrinsic and intrinsic factors can increase the chance of patients developing radiotherapy. So the extrinsic factors are type of radiotherapy or energy of radiotherapy, which is actually electromagnetic radiation or energy, how much is given, and radiosensitizer. Sometimes to increase the absorbency of the radiotherapy, they use radiosensitizers that can increase, that is a risk factor. And chemical, thermal, and mechanical irritants also can cause increase the chance of radiation dermatitis. So intrinsic factors within the patient, the age, extremes of age, nutrition status, comorbidities, obese patients, ethnic origin, UV exposure, infection, smoking, and alcohol also have an impact on the radiation skin reaction. Next slide, please. Before we start the treatment, we should conduct a patient, assess the patient's skin, and that's very important to see is the patient's skin, how good patient's skin health is, whether patient, or if the patient has already started with the chemotherapy, their skin may be very fragile. That can be an increasing factor for increasing factor for radiation dermatitis. And also identify the predisposing factors which could cause the severity of the reaction. And you should always record the skin condition and care, what type of care you are providing, what type of skin care regime you are introducing should be recorded and should continue on regular basis, at least on weekly basis. Next slide, please. It's also important at this point of time we are very much aware that skin tone differences between people, and it varies from 1 to 6 with the lighter skin to darker skin. So it is important to identify their skin changes. Sometimes patients may not, the dark skin tone patient develops skin damage which we are not able to identify. For example, recently I was called out to see a patient with a radiation dermatitis, but they thought it's a necrotic wound. It's a patient with a skin tone, the dark patient's skin tone. And when I checked, it was hyperpigmentation than a necrotic area. So it's so important that we should assess the patient's skin tone as well. So as I just mentioned, people with a dark skin tone, they will not their skin will not redden, but their skin will hyperpigment. So that's so important to identify that, and also uses a sensors touch to see whether those areas are warm, and ask the patient and listen to their perspective. And you should also use the photography for recording and monitoring if you're not sure how this change is going to happen. And when you assess, you have got a baseline assessments data. Next slide, please. This is just to show how to assess the skin tone. So this is a card we use at the Christie's to assess the patient's skin tone. So this is, as I said, 1 to 6. I'm not going to explain in detail about this. That is, it can take another 15-minute session, to be honest with you. Back to the skin reactions. Thank you. So main goal of care for patients with the skin reaction, initially to maintain the skin integrity and provide the hydration of the skin that will help these patients reducing their reaction during their treatment. And next is reducing potential for further exacerbation of the skin reaction. That's another goal if the patient started to develop the skin damage. And promoting comfort and compliance is very important. Unless you provide something very comfortable for the patient won't be compliant with you. And also important to reduce the pain. So pain management is a very important aspect of care as well. And further protection from trauma. Patient skin is very vulnerable, so avoid using any sticky tapes on the wounds. That's very important for these patients. And prevention of infection, I don't need to tell you how important it is. And if the patient has got moist wound, we should keep the moist desquamation. We should use a moist wound healing plan to prevent infection and protect the broken skin. And in case if you have got a patient with a malignant wound who undergoes palliative radiotherapy to control bleeding or excessive exudate, those people also develop radiotherapy skin reaction surrounding to their actual malignant wound. So that's controlling all the symptoms are also important for these patients. Next slide, please. So I'm just going to give you a little bit of idea about what Society and College of Radiographers guidelines for caring for these patients. They had an extensive literature review in 2022, and they found that genetic also has got an impact on the radiation dermatitis, and they also found that there is no one cream is better than other. So however, when I started the wound care, they used to use aqueous cream, and it is found that it should be used only for wash. We should not be using this cream for moisturizing the body. And there are debate about the use of deodorant, but this guideline says you can use deodorant if it is away from the part of the radiation going on. So if it's in the head and neck area, you probably can still use the deodorant underarm. And if sometimes you do see that skin gets very sensitive, and when you start the treatment, so it is important that you should stop if that's causing the reaction. And again, it's a controversy about the swimming. So this guideline says you can go swimming, but again, you should be if there is a skin breakdown, you should never go for swimming because that can increase the risk of infection. And also, perfume, people can wear makeup or perfume if it is not head and neck, but we are talking about the laryngectomy patients, so it's better to avoid the perfume and makeup on the face to avoid further skin damage and the irritation. And we also encourage the patient to continue their normal regime. Next slide, please. So personalized regime, patient come with a regime. Most of them use the moisturizing cream. We don't want to change that straight away to say because I like a QV cream or vinegar cream, but it's not that. If the patient is already using the moisturizing cream, should continue with that moisturizing cream. And unless it starts irritating the skin when we start with the radiotherapy. Sometimes if you try to change their plan, it can cause more harm than good. And there's no hard and fast rule that they should use one particular thing. They can pick up anything from the shelf which they use or which they prefer. Next slide, please. But what they should think, what we should do is actually, if the patient is choosing something from the counter, it should be SLS free, sodium lanolinic sulfate free. So those products can actually irritate the skin. So we should ask them not to buy those products. And also the same things like a lanolin. It is found in E45, which can irritate the skin as well. So those are the two instructions you should give. When they buy creams, they should not be using those two products. Next slide, please. Other general guidelines we provide to this patient is they should be wearing the loose fitting clothes, should be natural fiber clothing or cotton clothing, and they should wash the skin very gently, pat dry it, don't rub it, and we say avoid hair dryers or extremes in temperature. Heat or cool parts should not be used on those areas, it can cause harm. We advise them to avoid shaving if possible, but if they need to shave, they should be using the electric shaver. Again, we are talking about the head and neck patients, so it's very difficult to shave those areas. So try to ask them to avoid shaving those areas. Then makeup and perfume, as I said, they are allowed, but if it is in the face area, if the radiotherapy is going on that area, just make sure that we caution them with that. Next slide, please. One more click, Mary, please. Because grading for radiotherapy skin reaction, we use RTOG, radiation therapy oncology group scoring criteria. That's what we use at the Christie's. which will give us an idea what type of treatment each grading, each RTOG 0 or to 4, depending upon the severity of the skin reaction, we can advise on the treatment. Next slide, please. So at the Christie, we have got a radiotherapy-induced skin reaction guide, which we strictly follow at the hospital. And it just gives guidance from RTOG 0 to RTOG 3. And if there's a late effect, we have got a different guidelines, but we don't have a clinic to look after anyone with a late effect therapy. Next slide, please. I can go one by one with that. So RTOG 0, in case of RTOG 0, there is no visible change at that point of time. The main aim, as I said, is maintaining hydration and providing the skin integrity. That's the main aim. The treatment continue with the normal routine. Whatever moisturizer they are using, they need to continue with that, and we should be assess the skin weekly. Next slide, please. RTOG 1, there will be faint or dull erythema, epilation, and as I said, this may not be visible in this other skin tone, so it may not be an erythema, but you might see a skin change compared to the adjacent side of the skin. So management, again, the aim is promoting the hydration and improving the pain, and if the patient has got pruritus, that's why we should, sometimes the moisturizer cream should sort that itself. And so if the patient has got pruritus, we also advise 1% hydrocortisone if they complain of pain, and then we also assess them weekly. Next slide, please. So RTOG 2A, so there will be bright erythema. So if it is a skin tone like me, my skin tone is 3. You may not see erythema. You might see some purple or bruise discoloration in my body. And the patient can have plus or minus dry desquamation. Patient can have dry, itchy skin. And management aim again promoting the hydration and skin integrity and providing the comfort of care. That's most important there. So the treatment continues with the moisturizer, and if the patient has got pain, you optimize the analgesia and apply the barrier cream or spray if the skin is intact. Barrier cream seems to be effective for these patients. And if the patient has got burning sensation, you can consider using a hydrogel sheet dressing on this area, and 1% hydrocortisone also can be used for pruritus, as I mentioned for the RTOG 1. Next slide, please. RTOG 1, 2A, I mean, sorry. Yeah, so in grade RTOG 2B, there will be patchy, moist desquamation or X-rays started to come from there. Those areas could be very, very, very sore. There could be moderate edema in the area. And again, the aim is reducing the complication. We want to provide the pain relief. We want to continue with the treatment. If we don't want to discontinue the treatment at this point of time. And when it comes to this level, we don't want to use the moisturizing cream onto the broken skin. And if you think if there's a chance of infection, the signs of infection, you should separate from the erythema and from the radiotherapy skin reaction to the infection, because that area can be swollen, and it could be, if it is very, very painful, some the exudate is actually post-purulent discharge. So you take a swab to exclude infection. Then according to the need, the dressings should be done. This way, as soon as the skin is broken down, you should use the dressings to avoid getting the infection to that area. Some of the dressings we use, polymem dressings we use. Then we still use barrier film range of barrier film to the intact skin surrounding this broken skin, and we also use the silicone tape far away from the radiation dermatitis. And then if the patient still has got burning sensation, we still use hydrogel sheet. And hydrogel sheet probably it can be helpful for the burning sensation, and it does absorb a little bit of exudate, but the exudate level is high. You might have to think of something else differently. Next slide, please. So in Atos 3, you see confluent moist desquamation, and you can see yellow and green exudate coming from there. It may not be an infection, but the exudate itself will look yellow or green. There's a fluffy, few layers of the top layers are dying off. That's what is showing. And at this time, we want to reduce the complication further, and we have to treat Atos 3. Similar to Atos 2B, we stop the cream on the broken skin, we continue to moisturize the unbroken skin, and dressings and analgesia will be given to these patients. Atos 4, next, yeah. So this is a severe ulceration bleeding. As I said in the beginning, I have not seen one of these electricity so far. So it also says there's necrosis, patient can have necrosis, patient can have pain. Again, at this stage, we have to stop the radiotherapy until seen by the team, and then optimizing the analgesia. Usually we will wait for this to recover before we continue with the radiotherapy. Next slide, please. I'm just touching on the late effects of radiotherapy. I'm not going to explain much about it. But the patients can develop fibrosis, lymphedema, cellulitis, and telangiectasis. And one of the patients recently come back with a fibrosis after 2 years, and it's very, very difficult late effects radiotherapy reaction. However, unfortunately, we don't have a clinic for treating this late effect radiotherapy reactions at the Christie's. Next slide, please. This is just to give you an idea of how the late radiotherapy effects will look like. Next slide, please. So as a tissue viability nurse, I know the patient develop all of these reactions. My role mainly get to when the patient's skin, the radiotherapy team cannot manage themselves, they will come to me. And when you are doing when you are trying to advise on the wound dressings, what am I considering? I really want to look at the dressings, whether it's conformable, the size of the wound, how big the size is, where the wound is, whether this can be comfortable for the patients while this patient is going through this treatment, and how much fluid this can be how much fluid this dressing can absorb, and does this is acceptable to the patients, whatever I am trying to introduce, and it should be also easy to apply. Because when the patient is going for the treatment, they might have to take the dressing off every day. So it has sometimes in the day they do the treatment. Then when they go back home, they probably have to apply the dressing themselves. And the dressings, at least minimally, the dressing should stay for a day, and how it is adhering to the skin. Sometimes you have to use tape, but using the tape should be silicone tape. It should not be sticking to the skin, radiotherapy skin. And then whether I can prescribe something from the trust, and then patient goes to the community, and there if it's not available, there's no point of me prescribing this dressing. So those are the things I look at. And as we know that patient with a broken skin from the radiotherapy should always have a dressing, and unless they have the dressing and comfortable, and their quality of life is very, very limited with that. Next slide, please. So this dressing should be promoting good healing environment. And as I said, nowadays we provide moist wound healing. So the dress is what we usually provide that sorts of environment for the patient skin, which will help in healing. and also minimizing the risk of infection and further trauma. And then dressing should be non-adhesive. For the head and neck patients, we use polymer dressings, which I'll show you how we apply that. However, we don't have, as I said in the beginning, we don't have much high quality research in this area. And to me, I feel that it is because of the ethical reasons. If I know one dressing is working for one patient, I want that to be used for my other patient as well. So I don't want to go for, I probably won't go for a randomized control trial on this product, which I know it is working. That probably the way, that's the reason others are also probably not coming up with much of the randomized control trial, and lots of anecdotal reports are there which we can actually utilize, and then primary research also there. Next slide, please. Some of the dressing we use is silicone dressings, which we can which will help to adhere to the wound, but it doesn't actually break the skin when we remove it. I always tell my staff, when you take the dressing off, always use an adhesive remover to take the dressing off. When we put a dressing, always make sure you use the barrier film around the unbroken skin, so that this dressing will come off easily, we can apply easily, and the silicone dressing will not stick to the skin. That will be really, really useful for these patients. Next slide, please. So this is something, this polymam is something we use at the Christie, and I know in the community is very expensive. I do get call from the GP because they don't probably want to prescribe this. I do give them advice, and I make sure the patient get these dresses at the GP. Many of the times I have to speak to them, and sometimes it's easy for us when we send a referral to when we send a letter to the GP and we states the reason. And as a specialist hospital, when we send the request, most of them will do themselves. But when, just to highlight for the laryngectomy patients, if you look at the picture, polymer, sometimes people can just apply like a collar, but that doesn't actually stick to the skin near the neck. So you have to make 2 centimeter cut around the polymer and just use as a apply around the neck. Then the sticky tape, if you can see in the second picture, the tape goes on top of the polymer dressing, so it doesn't stick to the patient's skin. So that is very, very important for these patients, as we know. And this dressing has got very this is something we have been using for quite some time, because this seems to be clear up the wound, clean. It has got a property to clean the wound and absorb the exudate as well, and it also provides some pain relief to the patient. Next slide, please. And we need to know some of the tips how we can dress these wounds in the various other areas of radiotherapy. We have to improvise some things, and it's always you looking out of the box sometimes to see what is best for these patients, what we can use. Next slide, please. This is hydrogel sheet. It comes in, different companies have got different products, but whichever you use, hydrogel sheet is a hydrogel sheet, which is very, very useful for the pruritus. Next slide, please. Again, this is a barrier film which you can use for the surrounding skin, and some sort of silicone tape. These are the things I have just put it here for you to see. The next slide, please. I think we have come to the end of the session for this, but I'm happy to take any questions at the end of the session. Over to you,
That's
Faye.
brilliant. Thank you, Susie. That was so interesting from a speech therapy perspective. we really need to understand this so much more, specifically for our laryngectomy patients. That was really, really informative. And as Susie said, there will be an opportunity for you to ask any questions that you might have. So pop those into the Q&A. I've now got the pleasure of handing over to Monique, who is going to take us through the implications and management strategies. So I will let you carry on, Monique.
Thank you. So as Faye said, I'm Monique. I'm one of the speech and language therapists at Mount Vernon Cancer Centre, working with patients undergoing chemoradiotherapy treatment. I would typically see patients pre-treatment, during treatment and post-treatment for up to 6 to 12 weeks, and then we would hand them back to their local hospital, just to give you some context around the case studies later. And this is my wonderful head and neck team. So the role of the SLT, as per the Royal College and UK Head and Neck Guidelines, which were both published this year, indicates that the role of the SLT includes SVR, stoma-related issues and pulmonary rehab alongside the MDT, as well as swallowing and communication issues such as hands-free, esophageal voice, as well as trismus, etc. But for the purposes of today, we will just be concentrating on the skin changes in laryngectomy patients after radiotherapy. Next slide, please. So radiotherapy, with or without chemotherapy, is widely used and plays an important role in the treatment of patients with head and neck cancer. To understand how we manage the patients with radiotherapy, we have to understand a little bit about what happens during radiotherapy and how radiotherapy works, which is what Susie has so beautifully touched on. So radiotherapy works by passing through cells, and this high energy generates compounds called free radicals, which damage the cellular components as well as the DNA. And the objective is to prevent the regeneration of the malignant cells while allowing the healthy non-cancerous cells to recover. This process of cellular and DNA damage, however, has numerous side effects, and one of these is radiation dermatitis, which this slide is about. So radiation dermatitis, as Susie was explaining, is that skin damage or burn caused by radiotherapy. And in our laryngectomy population, we typically observe changes in the peristomal skin, the trachea, as well as the tracheal ring itself. And it's influenced by lots of different factors, as Susie was saying. But we know, for example, that severe radiation dermatitis is more prevalent with the use of chemotherapy agents such as cetuximab or cisplatin when combined with radiotherapy. And according to different studies, go back a little bit. According to different studies, it can occur in our population between 85 to 95% of patients, and this impacts their well-being, physical health, psychological health, and socially. Next slide, please. Thank you. So edema often occurs during the first 2 to 4 weeks of treatment and can persist post-treatment. And this is, again, the cumulative damage of radiotherapy. Next slide, please. For our general head and neck non-laryngectomy cancer population, secretion production and viscosity typically increase again in those final weeks of treatment and in those initial weeks post-treatment. This issue is, however, particularly pronounced for our laryngectomy patients who no longer benefit from the same heat, moisture, and resistance effects of the upper respiratory tract. Because of this, laryngectomy patients experience reduced mucociliary clearance, thickening and crusting of secretions, as well as increased secretion production, increased coughing, and shortness of breath. And those excessive secretions, particularly if they are dry or sticky, can lead to excessive cleaning, or in some of our patients, when they're picking off those dry secretions, this can lead to further skin breakdown and bleeding. So effective management of secretions enhances the integrity and the health of our skin in our laryngectomy population. Next slide, please. So microstoma, or stoma shrinkage, is a serious complication that speech and language therapists and the medical team need to be vigilant about, as this results in reduced airflow and gas exchange. Depending on the research that you read, it occurs between 9 to 21% of patients, and as per our UK head and neck guidelines and the Royal College guidelines, weekly close monitoring during treatment and regular reviews are advised. And according to, again, various studies, an airway diameter exceeding 12 to 14 millimeters is generally considered adequate. Next slide, please. So head and neck lymphedema, as Susie was saying, is quite common after radiotherapy, and it's that chronic, persistent and progressive swelling due to the accumulation of fluid that results from either the obstruction of the lymphatic vessels, removal or damage to the lymphatic system, and this can manifest internally but also externally, or it can be a combination of both. And we know that for our head and neck population, factors that lead to lymphedema include bilateral neck dissection, removal of the sternocleidomastoid muscle, large soft tissue resections, advanced disease, and radiotherapy greater than 60 Gray. So it's crucial to exercise caution with these patients to avoid any skin damage and tears, as complications may lead to, as Susie was saying, cellulitis and potentially bacterial and fungal infections. And with our patients with head and neck lymphedema, this has long-term functional challenges for them, as well as diminished health-related quality of life. Next slide, please. And again, as Faye was saying about that peak reaction being 7 to 10 days post-treatment, we know that radiotherapy builds up over the period of time, and then you have what is the peak reaction after treatment. So our skin management as SRTs or as an MDT, as well as things like pulmonary health, will change depending on where patients are in their pathway. Next slide, please. So again, why does knowing about how radiotherapy affects our patients, why is that important? So managing our patients is influenced by where they are in their treatment and what they're presenting like in front of us. For example, the devices we might use as speech and language therapists during treatment or in peak reaction may differ from those that we use when the radiotherapy toxicities or the skin have settled. And as speech and language therapists, we're always taking into account the skin condition when we're thinking about pulmonary rehab and SVR or communication. So let's think about skin ulceration and breakdown in a bit more detail to start with. So during the acute phase, skin is fragile and prone to trauma and infection, and skin breakdown may occur, particularly in those last few weeks or initially post-treatment. And the weekly accurate skin assessment is critical for these patients. Our nurses here at Mount Vernon embarked in an exciting pilot study with patients recently, where they were advised to use a hydroactive colloid gel from the very first day of radiotherapy throughout treatment instead of their general skin moisturizer. And remarkably, from their cohort, only one patient experienced skin breakdown. So thinking about this success, we're now delving into the potential benefits of using hydrogel or hydrocolloid base plates for our laryngectomy patients with or without a laryngectomy tube. And we're particularly interested in how these base plates could also have an impact on secretions and potentially enhance pulmonary health. We know as well that hydrocolloid base plates are being used for enhanced recovery programs for our laryngectomy patients post-surgery as well. So I think there's lots of evidence and research coming out, so watch this space for future developments. But generally, during treatment, laryngectomy tubes are often used, particularly with a neck collar. Sometimes laryngectomy buttons are also used. But generally, as Susie was saying, we want to avoid any strong adhesives as this will result in skin injuries known as medical adhesive-related skin injuries. Post-treatment, regular monitoring continues, and it's recommended that good skincare and creams are continued as well. New skin is very sensitive, so first steps may include using base plates that are skin friendly and contain hydrogel, as these are beneficial for dry, irradiated skin and support that healing. These also have a cooling effect on the skin and are easily removed with water. The downside to these are that they aren't as tacky as your standard adhesives, so it can be more problematic for our laryngectomy voice users, as the base plates can blow more easily. However, once the skin is settled, we want to transition our laryngectomy voice users back to using more standard base plates potentially. There is a very, very comprehensive webinar on skin changes and base plates that Atos recently recorded, so if you're interested in finding out more about skin changes, I would definitely recommend watching this. Next slide, please. So, the stoma. So radiotherapy can lead to inflammation of the skin, which becomes fibrosed, as Susie was saying, and in our laryngectomy patients, this contraction can lead to microstoma. And this narrow stoma can become partially or completely blocked, leading to difficulty breathing and respiratory distress, which obviously requires immediate medical attention. This is now their only airway, so again, we need to be particularly mindful of this. We need a really good stoma size because we need patients to be cleaning their stoma, cleaning their valve, as well as being able to change valves. So SLTs play an important role in assessing the stoma size and use of products to maintain stoma patency. During the acute phase, as we were saying, weekly stoma assessment is recommended. With our microstoma patients, laryngectomy tubes are frequently used. Alternatives include laryngectomy buttons, which can be paired with HME, so heat moisture exchange cassettes. There are also stoma studs. To minimize the use of strong adhesives like neck clips and standard base plates, sometimes neck collars are used or are beneficial. The downside, however, to using laryngectomy tubes is that they sometimes migrate upwards. You see patients come into clinic and the laryngeal tube is no longer in the stoma, for example, and there's compromised seal and air leakage everywhere. So laryngectomy buttons may mitigate this issue, but they require a lip to remain firmly in place. Thinking about post-treatment, if a patient's stoma size has remained stable and there are no concerns, patients may benefit from weaning off of a laryngectomy tube towards a base plate or using a laryngectomy tube within the base plate itself. For some patients, surgical interventions such as stomoplasty or stoma revision is indicated once the radiotherapy side effects have settled. So from this side, you can see that severe skin changes leading to microstoma require a different approach. Next slide, please. So head and neck lymphedema can impact the contour of the neck, and generally in the UK, practices that they refer to specialist lymphedema nurses for support and management. There is a strong emphasis during the acute phase on good hand hygiene, skin care and moisturising to reduce the risk of infection and cellulitis. Post-treatment referral to lymphedema specialists, as we've said, is beneficial, and their interventions may include exercises, compression garments, bandages, lymphatic drainage techniques. Where lymphedema impacts the seal of base plates, however, looking at stability base plates is sometimes helpful, as well as different shapes and sizes. In extreme cases, lymphedema post-treatment can impact the airway, as you will see in one of the case studies later. And in these patients, laryngectomy tubes or buttons are indicated. Next slide, please. So, secretions. So thinking about our normal radiotherapy patients again, they will have thicker tenacious secretions towards the end of treatment and that initial phase post-treatment. And this is no different to our laryngectomy patients. However, as we've touched on, if this isn't managed properly, this can result in airway obstruction, mucus plugs, decreased oxygen saturations, and airway obstruction. So, high humidification HMEs, such as the home or night HMEs, I don't know if you can see here, these retain moisture and heat, better than low humidification options, such as this one here with bigger holes. And these high humidification HMEs optimize secretions by making them less viscous and easier to clear, thereby optimizing their pulmonary health. In instances where breathing is more challenging, the lower resistant options, such as GO or Energy, or a bib may be better tolerated. And we know generally from the research that secretions are better managed with compliant HME use. Also, the thinner the secretions, the easier they are to wipe and clean, so we're avoiding further skin injury. And encouraging patients not to pick off their dried secretions also reduces that skin trauma. During as well, and sometimes post, the medical team may prescribe carbamazepine for patients. And then we have one person recently who had lots of comorbidities, lots of secretions, and we've referred them to physiotherapy for further support. So I wonder if this is perhaps underutilized in our laryngectomy population. Okay. So post-treatment, optimizing their secretion management and pulmonary health, getting patients back to base plates and HMEs, and the best HME for patients is the highest humidification option that they can tolerate. So essentially, the roundup from this slide is effective management of secretions will help enhance the integrity and the health of skin. Next slide, please. So, in terms of communication, being able to communicate is something that many of us take for granted. We use it to interact and connect with each other, build rapport and relationships, share experience and communicate our basic needs. And this is even more important for our laryngectomy patients who may still be working, they may have young families still. They may have to navigate transport to our centres and then communicate problems during treatment to the medical team, for example, pain or secretion. So part of our role as speech and language therapists is to maximise that functional communication as much as possible. But this means factoring in someone's skin. So during the acute phase where skin ulceration and breakdown or microstoma occurs, laryngectomy tubes or buttons are often used, and particularly even fenestrated tubes may interfere with communication and TEP speech, and patients may have to use other means of communication, be it mouthing, pen and paper, or high-tech options such as apps. Post-treatment, our aim is to get patients back to communicating as well and as functionally as possible. And it's no surprise that earlier that we can rehab someone's communication with a voice prosthesis, the better their mental health and well-being. So often the best way, in my experience, for patients communicating is to get them back to that base plate in HME. And in the early stages, this might mean working through base plates in a stepwise fashion until the skin is healed fully enough for those standard base plates. And also considering use of hands-free devices for our patients as well. So to summarise for the voice prosthesis slide, in order to support communication and voice use, again, we need to be navigating all of these skin problems. Next slide, please. So another thing to consider is quality of life, because this has a knock-on impact on the quality of care that patients receive. So this might be their physical health, mental health, spirituality, social status, etc. And we know that patients, if all of these needs are addressed and met, they're more likely to comply and do better with treatment and have a positive attitude. And our CNSs play a crucial role in supporting these patients as well. Next slide, please. So now we've got some case studies to go through. We've got 3. So this first gentleman was a 75-year-old male who came to us for post-op radiotherapy, 60 gray in 30 fractions over 6 weeks, following a total laryngectomy for a PT4A transglotic tumour. Next slide, please. So in terms of his communication, he also had a voice prosthesis placed at the time of surgery, and he was able to communicate well following surgery with base plates and HMEs. However, during radiotherapy, we had to switch to using a fenestrated laryngectomy tube, and because of the anatomy and the placement of the valve, this meant he wasn't able to fully achieve voice. In terms of his mood, there were no concerns. He had a very supportive wife and friends. His goals were to continue fishing with his mates, and he went 2 or 3 times a week, and he has done this all the way through treatment. Continue using his voice as much as possible. Move away from neckties, which we had to use during radiotherapy, and get back to base plates. So this here is a photo of him in peak reaction. You can see the radiation dermatitis, the peristoma area there. So he was using hydroactive colloid creams prescribed by the CNS team here. He was also referred to lymphedema for to the lymphedema nurses here, for the lymphedema around his surgical scars. In terms of his secretions, he experienced CTCAE, which is a common terminology scoring system, so grade 2 secretions. He used night HMEs during the day and at night, but if he was going out walking, sometimes he'd walk 5 miles a day, he would use his home HME, and he was nebulizing as advised by the team. In terms of his stoma size, this was stable post-op, but started to shrink on treatment. So he needed that laryngectomy tube to also maintain his stoma size. Due to the shape of the stoma, as you can see, a laryngectomy button was not appropriate. So for him, the next steps were, and actually we've seen him this week, we've moved him towards hydrogel base plates to enable him to get back to voicing and explore hands-free. And he was one of these patients as well, where you walk into clinic and the laryngectomy tube is quite prominent and there's air escape everywhere. So these base plates helped him voice and communicate much better. We've advised him to continue his night HMEs and his home HMEs if he's out and about. We'll continue to monitor his stoma size, and if stable, we can look at moving away or using short periods without the laryngectomy tube and see how he gets on. He's been advised to continue good skin care, moisturising, and in a few weeks we'll review his skin and hopefully work him back up to normal base plates. As he's a fisherman, we've had discussions around factor 50, skin protection, wearing a hat, covering up his neck, and fishing in the shade. Next slide, please. Okay, so this lady is a 68-year-old who had a PT4A-N3B hyperpharyngeal SCC, who had a total laryngectomy, partial pharyngectomy, and bilateral neck dissection, and came to us for post-op radiotherapy 65 Gray in 30 fractions over 6 weeks. So, as you can see, next slide, please. At the time, she didn't have a surgical voice prosthesis placed, possibly because of the extensive surgery. She communicated really well with mouthing, and occasionally the esophageal voice would creep in, but otherwise used pen and paper, but generally intelligible most of the time. Her mood was very good. She adjusted to being a laryngectomy well, had a very supportive husband, and her goals were to eat all the way through treatment, again, which she achieved beautifully, and the aim was to get her gastrostomy tube out ASAP. So you can see from the photo that she has some skin breakdown around the laryngectomy stoma, and we think this is because she was wearing the laryngectomy tube and sleeping on that side. She was again advised by the nurses to use the hydroactive colloid gels. You can also see from this photo that she's got quite severe lymphedema, and she reported that when she puts her neck down, it can obstruct her airway. So the use of laryngectomy tubes was definitely indicated for her, and particularly as well, because she came to us already with a shrinking stoma, laryngectomy tubes were used all the way through treatment 24/7. And due to the shape of her stoma, a laryngectomy button was not used. Secretion-wise, again, CTCAE grade 2. She used the night HMEs and was doing really well. So for her, the next steps were being referred to the lymphedema team so they could help reduce that swelling and airway obstruction. She would benefit from ENT review and consideration of SVR following treatment once the toxicities have settled. We could explore esophageal speech with her. We'll continue to monitor, or the team following her up will continue to monitor her stoma size and laryngectomy use. And as per the CNS team and the dietitians, good nutrition, continuous skin creams, and potentially in the future consider base plates and a laryngectomy tube if needed. Okay, next slide, please. So our final case study. This is a 67-year-old who had a total laryngectomy for a PT4A N1 piriform fossa tumour, came to us for 60 gray radiotherapy in 30 fractions over 6 weeks. Next slide, please. So as you can see here, he had surgical voice restoration, primary puncture, primary placement at the time of surgery. He had real difficulties coming to terms with diagnosis, his life-changing surgery, and this new normal, and he was overwhelmed with the amount of information that he was receiving. It was so important for him to communicate his basic needs and his frustrations, not only with the family, but the medical team here. And the only way he could communicate was with base plates and HME use, even though he'd been given a laryngectomy tube before by his surgical hospital. He just couldn't get on with the laryngectomy tube at all. Every time he put it in, it would lead to lots of coughing, gagging, and sometimes vomiting. And he was adamant that he was going to use his base plates all the way through treatment for as long as possible. So your typical fiercely independent head and neck patient. In terms of his mood, again, as I said, he was really, really frustrated. His goals were to get through treatment, to use his base plate, keep using his voice, use hands-free, go on holiday to Uganda and get his gastrostomy tube out. Our goals were to monitor his stoma size all the way through treatment, monitor his skin, optimize his communication and reduce the frustration, and this actually improved his compliance and optimize his HME use. So you can see from this picture that he started to get some peristomal breakdown around the tracheal ring, and this increased again just after peak. So this is, I think, week 5 or week 6 on treatment. He was advised by the nurses, again, using that hydroactive colloid cream. He really didn't tolerate the laryngectomy tube until the skin started to break down, where we said, you really need to be using this. And Atos advised a methylene dressing for him. He also used, he was also referred to lymphedema. Again, you can see not so well, maybe there's some lymphedema around the surgical scar. Secretions all the way through treatment were, again, CTCA grade 2. He was tolerating, so he's a slightly older patient, tolerating the extra moist HMEs, as well as nebulizing with the team, as advised by the team. We were very closely monitoring his stoma size, and his pre and post-treatment stoma size was 19 millimeters by 21 millimeters, so there were absolutely no changes to his stoma size pre and post. And he did really well. The next steps for him back in the day were to continue the skincare advice as per CNS and the Atos team, working towards hydrogel and then more standard normal base plates. We continued the stoma monitoring. We looked at, or the next steps for him were looking at hands-free, getting him set up for Uganda, and he was signposted to the Head and Neck Swallows charity and support from our centre here. Next slide, please. So, We've seen from this presentation that it's really crucial to factor in lots of different things, not only skin in our patients who are laryngectomy patients going through radiotherapy. And we know that rehab is always best undertaken as part of a multidisciplinary team. And the inclusion of all these health professionals and specialists improve health-related quality of life, decision-making for patients and patient satisfaction, and involving patients in their goals and making person-centered care. We need to be aware of skin changes and complications to optimise pulmonary rehab, stoma-related issues, SVR and communication issues as well. And I think that's it.
Thank you so much, Monique. That was so interesting, and it's really nice to get a different perspective as well on how you're managing sort of patients that have these difficulties. As I said, after Susie's talk, there will be an opportunity to answer some questions. So if you have any questions for either Monique or Susie, then please do pop those in the Q&A. We're now going to move on to a pre-recorded interview between one of our head and neck nurses, Lacey, and a gentleman who has undergone a laryngectomy and radiotherapy. So I'm just going to go ahead and share that, and we will resume back to the Q&A once the video has played.
Welcome to John and Lacey, who are going to have a chat with us now. John, about your personal experience during radiotherapy, and then Lacey, who's one of our head and neck nurses working for Atos, is going to tell us about how she helped John with his skin. So, John, if we start with you, could you just tell us a little bit about your laryngectomy journey? So a bit about your diagnosis and when you had your laryngectomy.
Laryngectomy was done on the 24th of April 23. So I'm done at UCLH.
Yeah. And how did it go?
Well, I've never been in hospital before, but it seemed to go okay. I was about 3 weeks in there.
Okay.
I think they were very efficient hospital, I was very well looked after. I think I don't know what I'm going to compare with anything, so it was good. I would have thought it was good. In fact, I would have thought it probably was a class. I can't really say that. But I don't know.
But it seemed to go well to you.
Yeah, everything seemed to go well, yeah.
So then after your laryngectomy, you had to have some radiotherapy.
Yeah.
Can you tell us a bit about how the radiotherapy was?
Well, initially it wasn't too bad. I had 6 weeks. That's 30 days continuous, Monday to Friday. My biggest problem was myself, because I'm the care of my wife. We had to get from where we are in Loughton up to some falls, which is about getting back. And I couldn't always get someone to look after my wife.
Right.
Occasionally I did, we had to get up there and get back. And getting on the bus and the tube was quite stressful to get there in time for the radiotherapy. But in fairness to parts, they were quite flexible. They'd put you on a machine at the earliest opportunity anyways. I found that they were very efficient and fast. They were good.
Good.
The lady there, I can't remember who's it. Do you know the lady? Asian origin lady. She was very efficient. She was very good. Organised it very well. In parallel with that, and there were the in the 5th week, there was a transport strikes,
Oh,
and I didn't know how I was going to get there. I mean, the made I considered just got the Uber, but, I didn't. But the lady I'm talking about organised minicab transport for the last week,
right.
and I was very glad of that because she organised it for 2 of us, which I believe is contrary to NHS rules. I don't know. She meant rules. I said, well, I can't go without my wife, so I can't. So she arranged that. But I think when Lacey first saw me, that was the 5th week, that I was very exhausted.
Mm.
One of my sons came in the Friday afternoon. He said, I know you got your last legs. He
Right.
said, so I was very weak. I slept most of that weekend, and I was okay the last week, but I get myself up to get here over and done with, get a haircut, which I had on the 29th of July. Cost me 20 quid down the road.
Yeah, it's a very tough treatment, isn't it, John? Particularly towards the end, and with some transport issues thrown in. That sounds very, very challenging. Lacey, do you want to tell us about why you were referred, John, and what your involvement was?
Yeah, so I received the referral from the speech and language therapist who were looking after you, and they had some concerns because obviously you had a lot going on at home with being the main carer for your wife. And with the daily travel for radiotherapy, they felt that having someone pop out and see how things were getting on would be important. So we had arranged that initial visit, and I don't think that, now I know you really well, you certainly weren't yourself at that point. And that's not unusual for someone going through radiotherapy, in the fact that you're not at your best. You've really exhausted by that point. And in your case, you had really significant radiation dermatitis, and you were still wearing your base plates at that point. And I think maybe that information had become a little bit messed up in all of the information that you had to take in during your time during radiotherapy, that it was something, you had got into a really good routine of managing your base plate and using your HMEs daily. I don't think there's really been many days that you've not used your HME since the surgery, which is great. But in this instance, the base plates obviously weren't helping that skin heal. So at that point, you were still using a hydrocolloid base plate, but the skin underneath was bleeding.
Right.
Completely broken skin all around the sides of the base plate. So we stopped that, didn't we? We stopped that there and then. I got you using your radiation cream a little bit more often, and using nice soft gauze and some saline to clean that skin relatively frequently as well, just to reduce your risk of infection. We sized you for a Larry button, and you had your Larry tube already, but I think that the Larry tube you were having a bit of a problem with at that point, and that was partly because I think you had a little bit of edema
Right. Yeah.
as well. So obviously that was becoming a little bit more uncomfortable. So the Larry button, just with it being the shorter length, was a bit more comfortable for you.
It might be what edema.
That's like swelling of the tissues, fluid.
Swollen.
Yeah, so it just
Yeah.
wasn't fitting properly, and I think that was causing you a bit of irritation, a bit of coughing.
Just shows how sore that skin must have been for you, John, if everything was bleeding and swollen. Sounds, yeah, really, really difficult to manage.
So I think at that point, it was probably one of the worst radiation dermatitis cases that I'd seen. But we didn't discuss that at the point, John, did we? It's only more recently that we've discussed quite how bad your skin had been.
Well, I didn't. It wasn't really. And that was normal after radiotherapy. What do I know? You know?
Yeah, nothing to compare it to, have you, John? Yeah.
So
I
I
think you
think
managed it with some gauze initially, Lacey, and then
yeah. So the switching and stopping using the base plates was ideal. We at this point you weren't on the Provox Life range, and we didn't think that you were going to be able to cope with the lunar HME because of the amount of secretions you still had from your radiotherapy. So we didn't have access to the hydrocolloid, the hydrogel dressing, which would have been quite a good point in healing. So what we did instead is we started using hyaluronic acid called Jalasom. And I hadn't heard of this product before, but I was at the Swallows conference, and they had a lot of radiotherapy companies there, and who created creams and gels and things. And they had this brand new product called Jalasom, which was really, really good in repairing that skin barrier again. So that allowed that skin barrier to heal much more quickly than we had anticipated it healing. And it reduces scarring as well. So where we were expecting to have quite a lot of pockets of skin where it might be a problem later on when we come to put base plates on, and potentially having areas where infection and bacteria might want to find its way, we haven't been left with any of that, and your skin's lovely and smooth. And has just healed beautifully. We did run into some some different problems once we'd healed the skin, though, didn't we? Do you remember how that all happened?
No, you tell the story.
So I think that you'd got so good with your routine by this point that it was just an extra task for you to do in the day. Yeah, you were a little bit quick with your removal, and when we'd worked so hard to get your skin back to perfection again, we didn't want to kind of undo all of the work that we'd done. So we worked on the removal technique, and at this point we felt that actually switching product lines over from Provox to Provox Life would be beneficial. And that's when we introduced the night base plate to use when you wanted to have a bit of a recovery day for your skin. And you found that hydrogel, that really soft, watery one, was really good at healing your skin over a couple of days. And we use it more as a treatment rather than you'd use that you wouldn't use that every night. You'd only use that when your skin wanted a break. And then we continued to work on your technique of removing your base plate, and thankfully so far everything's been really good. So would you agree with that? You've not had any skin soreness?
No, a bit of bleeding, but I'm very healthy. Anyway, the blood's coming from the valve, where the valve is, so I don't know where it's coming. There's only a little bit of blood anyway.
Okay, well, that's not common for you, is it?
Sometimes you'll get it
when you're using the brush.
Yeah.
So it's probably behind the valve.
Okay.
Yeah.
We'll have a little look at that.
Yeah. And how long did it take for the skin to recover, Lacey? Just thinking of perhaps clinicians listening and thinking when would be the right time to reintroduce an adhesive.
So I think my initial appointment with you was on the 20th of July. And I think that we had recovered the skin within the space of about 5 weeks from the point of very severe radiation dermatitis. And you were back to using hydrocolloid base plates again quite quickly, weren't you?
Yeah, that's actually quite quick. It feels quick, doesn't it, given the severity that you were saying for the skin reaction to the radiotherapy. And your skin's completely fine now, John, except you've just got this little bit of bleeding that we're wondering if it's coming from the valve. But otherwise, you've recovered well now.
It's nothing. Forget about the bleeding. It's nothing.
Great. And is there any advice, John, you think you would give to any other patients that were going through radiotherapy after they've had a laryngectomy? Is there anything that you found particularly helpful or anything you wish you'd known beforehand?
Well, I'm not sure about it. I mean, it's the mask. It's necessary for the radiotherapy.
Unfortunately, yes.
That's most uncomfortable way in radiotherapy, that because it's supposed to be aims a measure, but it doesn't. There's no tolerance on it at all. It's not sure how long the radiotherapy was each time. Was it 3 minutes? 5?
Yeah,
I don't know.
About 5 minutes normally. Yeah.
Yeah, I think 5 minutes, but yeah. It was quite tight, and some of them were very rough when they put it on. You know, they force it on, so it depends who you got on the day, because they clamp it on.
Yeah.
No, if you need to have it, you need to have it. I don't know what else you can do.
We talked about making sure that you were remaining hydrated.
Yeah, drinking plenty of water, yeah.
Yeah. And that helps both with the secretions, your skin, and the headaches that you can sometimes get with it as well.
Yeah. Doesn't seem like any side effects from the radiation above and being tired. I never know whether it's because of being age or whether the radiotherapy, I don't know the difference between the two really comes out.
Well, I think that it's only now when you sort of look back that you realise that it was quite a rough time for you. I think in that moment you were just so focused on getting through the treatment that it was a means to an end during the system. And I think, again, because you hadn't ever had sort of any hospital interaction in your life prior to all of this, you just didn't really have any understanding about how you should be feeling. So I think what's quite important for us as clinicians is that we help give you those tools to understand what is a normal experience, or what is a more usual experience, because normal isn't measurable for anyone. And we can give you parameters of what would be acceptable, and at what point do you need to let us know that something may be going a little bit wrong for you.
Yeah, I did the whole lot of organisation was really fun. I'm very pleased with that. The real complaint is the initial diagnosis took so long, and I think it's some bug passing. I don't know what went on her whips cross, but I think I was into December of the year before, and I first attended the ENT, and I had several sessions up there, and it's due to when I first started off, because I choked twice eating, and about a month apart, so our GP referred me to the ENT. First of all, it was what do you call the acids in your stomach?
Reflux.
A reflux. It was that. Gaviscon or whatever, you know, so and then they went on. Then it was Gaviscon twice, and at any time you saw somebody up there, it was I don't know, it wasn't analytical at all, and it was only eventually my son, a lawyer, drafted an email to the GP and said, you know, he's got to sort this out and been up there so often. And he came up the hospital with me, and an Asian doctor there put the scope up the nose and that, and then he decided there's malignancy.
Right.
And I've been down there for a year or so. And then I got a phone call one Thursday. I thought he was ready to go to Cambridge to celebrate my 80th birthday. I get a phone call from Mr. Berg, I think he's the chief body down there. He phoned me up one of those. He said, why aren't you here? I said, well, I would be there if somebody let me know by text, like a telephone call or email. But he said, I can only be here till, I said, I can't get up there for another hour and a half. He said, well, I'll wait till 1 o'clock or something. I can't remember besides how old of it. So I got up there. Unfortunately, I got my son on WhatsApp when he gave me the good news that I had stage 4 and I had no choices. I had to have surgery. I don't know. I used to go to Dr. Dad.
Oh. So a bit of a roller coaster ride then, John.
Well, prior to the surgery, yeah. But once I had the surgery, everything seemed to fit in. But I don't know what, if I'd been diagnosed earlier, would it have been any different? I don't know.
It's one of those what if questions that I think a lot of patients ask themselves, isn't it? It's challenging.
Yeah,
But
well,
you're living well now, are you, John? You back to your normal hobbies?
Yeah, I have lobster every night and the roller champagne.
Oh,
Sounds
lovely.
Yeah, no. Well, I don't do. I don't know if it's the effects of the cancer or just age. I haven't got the energy that I used to have.
Yeah.
One good thing that's come out of this is that my sons have realised that they step in while I was in hospital to look after mum. They realised that mum's condition much better. Well,
Good. So a good thing has come out of a difficult situation.
yeah, that's it.
And the good thing is that you're always been really, really sociable, haven't you?
No,
And one of the biggest things, and what we really needed to heal your skin for, is that we wanted to try and start you on the hands-free device, and you've been able to use that really successfully for short periods.
I'm not sure.
Yeah.
You're going to just increase your practice of that, aren't you?
I'm a bit lazy, I suppose.
But when we do practice, you've been really, really good with it. So
And
it's
Lacey,
just keeping up the practice.
And Lacey, any sort of final words of advice for other clinicians that perhaps might have patients having such a severe skin reaction? I love the way that you looked out a new product to try, which you found really successful. Is there anything else you would suggest?
Yeah, I think. Or did you want to say something? I think from my experience, I think we just need to strip it back to basics. So remove all of the aggravating factors, work out if anything that we're using could be causing more damage. So in John's case, I think we needed to make it really, really basic. So that's why we went just purely to saline and non-woven gauze to be his cleaning. Allow that initial healing to take place so that the skin barrier is starting to form again. The hyaluronic acid was really, really beneficial, but is not is not really, I don't think it's available in prescription at the moment. So either
Right.
you would have to ask your patients to go and purchase that, or not use that step. But it was good in John's case, and I think we probably wouldn't have got the healing that we did had we not used it. But that being said, the hydrogel or the night Provox Life dressing or the Luna is really, really good at helping to repair that skin barrier as well. Yeah. And that needs to be the focus, is that we need to get the barrier repaired so that then we can reduce the risk of infection, which is going to be so high during that period. And that would have been the last thing that you needed. And obviously then starts preparing the skin back for base plates, because once everything settles down, you can get back to the focus, which will be back on communication again. Because it's incredibly frustrating if you can't communicate reliably. Yeah. And if you're not feeling 100%, and in your case, you definitely needed to.
And after radiotherapy, being able to communicate externally, my wife can talk on the phone, but she can't operate the phone.
Right.
And I couldn't use the phone. The communications were very difficult.
Yeah. Well, it sounds like you've got through that challenge with Lacey's support, John, and thank you both for sharing the story with us. It's really valuable while we're thinking about skin a little bit more and how we can help.
I think you should have more lazy or equivalent info for people who, I've got boards, thousands of other people who haven't got any family backup. I think they probably need much more visitation from like lazy. That is what I would recommend, to give them confidence, especially when they've just finished radiotherapy, perhaps cut it down, but probably 3 times a week, even before that, down to 2 times a week, and once a week, and then whenever,
Yeah, it's so valuable having someone like Lacey able to come and see you at home, isn't it, during the challenging time and all the difficulties with travelling and.
Yeah, but it's also helpful. That's the professional bit, but it's also helpful to have somebody to do the day-to-day thing, help you with whatever,
Yeah, we need to clone Lacey, I think.
Yeah, that's right.
Well, thank you both for your time. That was really insightful.
Okay, so we've now seen the video and we've heard from our presenters. So I'm going to invite all of our presenters back onto the screen so that we can see everybody. There we go. We've got Monique and Susie. Fantastic. And Lacey hopefully will join us as well. Oh, there's a room. There she is. Thank you all so much for taking the time, especially on a Friday evening, to present on this particular topic. It's such an interesting topic for lots of different reasons, but it's nice to have those different perspectives as well. So again, for those who are listening, if you will have any questions, do pop them in the Q&A. But we have had a couple of questions ahead of time. So I think this first question is really aimed for Susie, because I know that you mentioned that you've done a lot of work around the different skin tones. And the question is what is the clinical assessment and management of these other skin tones before, during, and after radiotherapy, especially?
The management is the same, but identifying that on time is the most important. So I was also, as you mentioned in the beginning, I was also actually talking about the skin tone in the ESTRO conference. And again, they talk a lot about the different skin tones, how it is affecting. So one of the misconception is with the patients with the darker skin tone doesn't burn, but they're strong. They do burn, and they do get the radiation dermatitis as well, very often. But how we identify that, we really need to identify that. That's where the skin tone assessment helps. And many of I listen to Rad Chat a lot, and the Naman who leads on it, he talks a lot about he's a radiographer himself. So he has taken lots of initiation in within the radiographers to identify the skin changes. So as I said, the management doesn't change, but the early identification is important. And if you identify early, we can start the management early.
Absolutely. So yeah, I mean, it seems very logical, but just opening out to Monique and Lacey, how do you find identifying those darker skin tones with the difficulties that we've seen today? Is it as easy as it is for your average patient, or is it that bit more difficult? So maybe Monique.
Yeah, it is. Yeah, it is difficult. I'm not sure I'm the best expert at this. I think Lacey may have a better. Yeah.
Yeah, Lacey.
Yeah, in my experience, you can get so many different tones. So it's quite helpful. I always, if I haven't seen the patient before radiotherapy, I'll ask to see maybe a picture of them, where I can see what their natural skin tone is normally prior to treatment. And sometimes it's when I arrive at the patient's house and I can see a picture of them on the wall and I can see, okay, this looks different now. And you can get variations from like maroon, very, very dark, to sort of an ashen grey in certain skin tones. So it can be challenging if you aren't aware of what their baseline is. So you just kind of have to find a workaround for that. But typically, if you're seeing, patients who are undergoing radiotherapy all the time, then you know which sort of areas to look out for changes. So it does make it a little bit easier.
Yeah, no, that's really helpful advice as well. And having that baseline of what somebody's skin tone and even the contour is like pre-radiotherapy can be really beneficial. And also having that grading tool as well is it's great resources to have on hand. Thank you for that. So maybe a question for Monique. So what is your experience and opinion on using base plates immediately post-surgery for our salvage laryngectomy patients?
Very good question. So I know that there is some work at the moment in terms of enhanced recovery programs at using hydrocolloid base plates post-surgery, quite soon post-surgery, to help with that healing. I haven't experienced that myself, but I know that they were looking at putting this in place at my previous trust before I moved to Mount Vernon. But I think there is a role for hydrocolloid base plates immediately post-surgery, definitely.
Yeah, absolutely. And Lacey, maybe not necessarily within your community role, but previously, is that something that you've come across?
Yeah, it's very changeable from surgeon to surgeon, even within the same trust of their preferences. My experience has been really positive with the early adoption of hydrocolloid base plates immediately post-operative for these patients. Haven't seen any ill effects from it. So yeah, I mean, I've only had really positive experiences of nursing these patients immediately post-op. And I think the benefits of the early adoption of HMEs is the biggest win. And certainly it does definitely improve the sort of the patient's ability to get on board with the day-to-day care of their laryngectomy as well.
Yeah, so facilitating that sort of earlier rehab journey as well, and going back to what you were talking about as well, Monique, about that pulmonary rehabilitation, and compliance as well, because they know no different, so they're able to tolerate it a little bit more. That's really helpful, thank you. So another question for Susie, perhaps, or actually Lacey as well. Which moist desquamation creams are safest to use around the stoma? So maybe
For the
Susie?
for the moist desquamation, I do use hydroactive colloid gel actually. So hydroactive gel, that's a first choice of mine actually, and this is in the guide as well. I mean, Christie guide. And one of the things we can with the sometimes if you can't put a dressing on, you can still use the gel. Two different for the um, severely oozing wound. There's another product called Forte and Hydro. We can use one of those products, and I have seen on its own you can use as well. So that is really good as well. And I didn't mention that. I was more concentrating on the dressing type, but this is really important, which Monique mentioned quite a few times how this is treated. That is the first line before we go into actually polymer dressings. To be honest with you.
Right, okay, that's really useful to know. Lacey, any other tips, suggestions?
I don't think I have
Pretty much
anything to
the
add.
same.
Yeah, I think Susie covered it really well in her presentation as well, as did Monique when you talked about this. I think as long as you avoid, the things that are going to be harmful, and they are the lanolin, the SLS, you need to be SLS free, then I think you're going to be okay with if you focus on the hydration.
Yeah, okay, that's really helpful. So another question is around the use of base plates during or adhesives during radiotherapy. And maybe we can come to Monique with this. So which base plate would you use? Would you use it during treatment through the planning scans, or would you remove it at that point?
So at our trust, it's variable in terms of the planning. If we start with that first, so some patients have already come planned and they're using base plates, so they recommend continuing their base plates during radiotherapy, because when they make that mask or that shell, they're making it with millimeter accuracy. So any small changes can impact the radiotherapy. So, for example, if someone's planned with a laryngectomy tube, they'll generally have to wear their laryngectomy tube during treatment as well. So the same applies almost for base plates. The difficulty is, though, we obviously, if their skin is breaking down, we really don't want to be using base plates that are going to cause some more trauma to the skin. So they will, if they're planned with base plates, ask them to not use a base plate because that's then flatter, and then they'll recalculate volumes for the radiotherapy, and if it's okay, then they'll continue. So it really does depend in terms of the planning side of things and during treatment. If we are going to use base plates, it's the hydrogel base plates during radiotherapy. Post-treatment, again, tend to go for hydrogel, although currently on our caseload we've got one or two that actually prefer the hydrocolloid, but they are slightly further out from treatment now. So again, variable, but generally go for hydrogel or the night base plates over anything else.
Okay, that's brilliant. So I'm aware that we're coming to the end now of the webinar, and it's been an absolutely amazing Friday evening for me. Not that I don't have a life, but I do. But it's been absolutely brilliant. I appreciate all of your time and the effort that you've put into the presentations. I'm sure that the participants and those that will watch this back will get so much benefit out of the advice and the protocols and the practice that you guys have demonstrated. Obviously, for anybody who is watching, if you do have any questions after the event, then please do drop us a line. I'm sure we can put you in touch with either Monique or Susie, and hope you have a great weekend when it gets here. Thank you.